Hi, everyone. My name is Rosemary Morgan, and I'm really delighted to be here today. I am based in the U.S. I'm actually from Squamish, which is right, hopefully where a lot of you are from, near Vancouver. So I'm even more delighted to be here today to talk to you about creating a gender responsive health system and ask the question, does COVID-19 provide us with an opportunity to build back better? So why is this an important topic? Well, it's an important topic because health systems are not gender neutral. And what do I mean by this? Well, health systems are social systems. They reflect and reinforce the cultural and social characteristics, so the social order within society. And what I mean by that is different gender inequities that exist within society, or racial inequities, or other forms of inequities can also be found replicated within the health system. And in my work, I'm a health systems researcher. We use health systems models a lot to understand how health systems function, how services are delivered, how they're governed. And often these health systems models, they'll have equity as an outcome. So one of the outcomes of health systems is to improve health outcomes and to improve health inequities. However, what they're missing is the fact that equity should also be an input, and it should also be part of health systems processes. So how can we expect equitable outcomes in the delivery of health through health systems if we don't have equitable inputs and equitable processes? So how are health systems gendered? So there are multiple ways in which health systems are gendered. The ones on the screen here are a reflection of some of the ones from my work, predominantly based in low and middle income countries. Things like the fact that health systems sort of reinforce women's care roles, particularly in professions that are dominated by women, like midwifery, nursing, and community health workers. The fact that governance structures are dominated by men, despite the fact that the majority of health workers are women. And that the final one on here, the lack of sex disaggregated data and the gender data gaps, is a really important one, because there's so much data out of health information systems that are just not reported by sex or not reported by other stratifiers. And we know we need data to identify problems. We need data to find out where disparities are. And if we can't identify problems, we can't address problems. And this is a major implication within health systems. Today, I want to focus on a few specific examples of the way in which health systems are gendered, focusing on human resources for health, focusing on medical products and technology, as well as governance and leadership. So starting off with human resources for health, we know that women are drivers of health. And this slide and the slides that I will be presenting on are from a recent report from the World Health Organization called Delivered by Women, Led by Men. So women make up 70 to 75% of the 200 million workers who contribute to the health and social care. They deliver to around 5 billion people and contribute 3 trillion annually. So if you look, for every 10 healthcare workers, 7 of them are women. They are drivers of health. But what are some of the ways in which we are seeing sort of gender inequities within human resources for health? So this slide here shows sort of vertical, the feminization of the health workforce. So specifically, if you have a look, we see the proportion of women in sort of health and social care sectors compared to the proportion of women in other sectors. And we can see there's a lot more women represented in health and social care. Another way in which human resources for health is gendered is through what we refer to as horizontal segregation. And this means how certain professions are dominated by women, and the ones on the left here on the screen are the ones that are more dominated by women. And as you go to the left, they're dominated by men. And you can see some very specific health professions in there. You can see dental assistants, you can see nursing, you can see doctors and surgeons, and really see kind of the how professions are horizontally segregated. This next slide looks at, in this case, academic medicine in the United States, but the percentages of women reporting sexual harassment compared to men. And this is quite a stark difference. And we do see this across different professions. And it really does affect the ability of women healthcare workers to have decent working conditions. The next slide is a big one. It's about the gender pay gap. We refer to this quite a lot when we're talking about gender inequities. And the graph here shows, it's again based in the United States, but shows the percentage of looking at nursing specifically, and women versus men nurses, and the fact that women nurses are making less. And we see this as a pattern throughout multiple contexts. So what about COVID-19? Well, this screen here shows the proportion of health workers which are infected with COVID-19. And as you can see, women healthcare workers are disproportionately infected across multiple country contexts. We don't have data from a lot of countries. So this is from a website called Global Health 50/50, which is reporting real-time sex desegregated data and the data that is available. So the WHO has reported that over 35,000 healthcare workers worldwide have been infected with COVID-19, and I'm sure that number has increased since that reporting. In September, there was a report from Amnesty International that stated that the global toll of healthcare worker deaths due to COVID-19 had reached at least 7,000. And we're now in November, closing December, so I'm sure that number's increased. In certain countries, we're seeing higher numbers, like in Mexico, and the US and Brazil are leading. In Mexico, and as of September, 1,320 healthcare workers had confirmed to have died. And all of this is going to have severe effects on healthcare workers' mental health. So multiple studies that have been coming out have revealed the psychological toll the virus has taken on healthcare providers. One study reported that more than 40% of healthcare personnel reported that they exhibited anxiety symptoms. More than 46% had reported depression, 32% reported insomnia, and 69% had high levels of stress. Recently, an International Council of Nurses report stated that there is strong evidence that nurses are experiencing unprecedented levels of stress. It went on to say that nurses are at high risk for full-blown stress response syndromes, anxiety, depression, post-traumatic stress disorder, chronic illness, and burnout. And these are serious things that we need to consider. Why are we seeing this sort of disproportionate rate of COVID-19 infections amongst women healthcare workers? Well, it's partly due to the types of work that people are doing, that women are doing, and the patient contact. It also has to do with personal protective equipment shortages. But also, as you can see on this particular slide, and we see this as a common thing throughout multiple professions, same with construction, same with police force, that personal protective equipment is made for the male body, meaning it's putting women at risk. Not just women healthcare professions, women police officers, women working in construction work. And you can see from some tweets here of it's anecdotal evidence, but of women healthcare workers failing their fit tests. What about health systems leadership? Well, as I stated before, 70 to 75% of women, of healthcare workers are women. But only 25% of leaders within the health system are women. That is a disproportionate number. This graph here shows the number of women, of ministers of health, which are led by women, which is 31%. Turning now to COVID-19, this is a graph from Operation 50/50, and it reports the representation of women on COVID-19 task forces. And as you can see, this was in the beginning days, between 10 to 20% of task forces, women were represented on task forces. In some, there were zero. So what can we do about all of this? Well, in our work, we talk about the need for a gender responsive health system. And what do I mean by that? Well, a gender responsive health system is one in which takes into consideration the intersectional needs of women, men, and gender minorities in the development, delivery, and management of health systems across all health system areas and across all levels. So this also includes healthcare workers. This diagram on here is from a brief that we had created about bringing a gender lens into health systems policy. And in that, we really break down the different ways in which from the different health systems components, we can bring in that gender lens. But again, bringing us back to COVID-19. And the question that I started off with is, does COVID-19 offer us an opportunity to build back better? And we are arguing that yes, it does. So COVID-19, if nothing else, has really drawn attention to the inequities that exist and disparities. In particular, with relation to the health system, it has drawn attention to the gender nature of the health workforce and the vulnerability of women healthcare workers in particular. It's drawn attention to the need for social protection due to women's dual care responsibilities, like the need for childcare, paid sick leave, equal pay. It's drawn attention to the importance of mental health and the need for mental health interventions. It's drawn attention to the lack of women's representation within leadership within the health system. And it has also drawn attention to the effectiveness of women leaders. Look at some of the countries that are doing well in the response to COVID-19. Many of them are led by women. So COVID-19 is showing us that there are different ways of working, that we are able to adapt. If we are going to minimize the gendered effects of COVID-19, we do need to act now because, let's face it, COVID-19 is having an effect on gender equality everywhere within the health system and elsewhere. And the question really is, how bad is this effect going to be? Can we build back better to a place that is better than where we were at the beginning? Because let's face it, we weren't in a great place. The gender inequality existed before the pandemic. We need to ensure that our pandemic response plans and recovery plans are gender responsive. And this coincides with gender responsive health systems. So how can we use the pandemic to build back better, to ensure that the systems and structures in which we live and work are equitable for all? We are in a project that we are working on where we're seeking to really understand and mitigate the real-time differential effects of COVID-19 across 9 country contexts, including Canada. The project that was mentioned at the beginning, we're starting a project funded by the British Columbia Women's Health Foundation to specifically look at the gendered effects on healthcare workers, including midwives, nurses, and long-term care workers, so that we can do something about it, so that we can ensure that we create gender-responsive pandemic plans that consider the specific needs of women and men and gender minority health workers. And I should say the intersectional needs. It's not just gender needs, it's the intersectional needs. We also need to look at the different work that's already been done in different contexts. In Canada and in Hawaii, for example, the different feminist recovery plans have been developed and or implemented. So we put together a brief that compared these two. And some of the specific recommendations included the need for pandemic responses to be underpinned by data that is disaggregated by sex and other markers of inequity, at all levels, the need for women-led organizations, feminist academics, and women's experiences and ideas to be at the center of recovery efforts in government bodies, official constitutions, and online spaces. I would also argue within health systems and health systems leadership. The provision of universally accessible free childcare and long-term elder care should be central to these economic recovery plans and our attempts to open up the economy, and that we need to really support women in female-dominated economic sectors, including healthcare workers, which have been particularly hard hit by the pandemic. Another thing we're doing is bringing people together. I co-coordinate Gender and COVID-19 Working Group along with Julia Smith at Simon Fraser University and Claire Wenham at the London School of Economics. And this currently has up to 600 members across academia, civil society, and government and multilateral organizations. And we're working to not only galvanize priority for the issue of gender and equity and intersectional gender and equity within COVID and health more broadly, but we're working to collaborate and amplify messages to really ensure that we have action on these issues. And with that, I will thank you for having me here today. It was a real pleasure to come and speak with you, and I will end there.